Good afternoon. Okay, so I'm going to try not to fall off the back of the stage. And I'm going to try to remember to keep this up here because I was not told of the dress code, that I somehow needed to wear something with either a lapel or a pocket or a belt to put on a regular mic. So bear with me, please. In addition to my role as superintendent at the North Dakota State Hospital, I am also the chief clinics officer for the Human Service Centers. So with in mind that we as one system work together to provide services across our state. The public behavioral health system is made up of a variety of things. Public behavioral health, originally just large state hospitals, were, treated clients in large state hospitals, and for clients who improved naturally with farm and community, that worked very well. For clients who did not, however, they were often isolated in padded rooms and frequently secluded, until at which point the science and humanity advanced in such a way that there was identification of what actually worked. With that, with the advances of science in the therapies and medications, in time, community behavioral health was developed. With the development of community behavioral health came the recognition that the public behavioral health system became what was considered the safety net to provide a core continuum of services for a priority set of youth and adults. So if you consider starting in a hospital, now recognizing that people were best served in community settings, then recognizing also that there was a variety of things that could occur for individuals. And then public systems were designed and reserved solely for those other services that fell outside of the realm of private providers, for example, and therefore became known as safety net. So the public behavioral health system as safety net developed over time, and ours in this state that serves 20,000 individuals annually includes the following: one state hospital with 85 adult psychiatric beds, 46 residential adult substance use disorder beds, and 45 residential beds for dangerous sex offenders. In addition, there are 8 regional human service centers and 4 satellite clinics open 5 days weekly, serving a variety of individuals with a combination of psychotherapies, case management, and medication services. In addition, there are 33 outreach sites open 1 to 3 days weekly with case management and therapy services. There is also one 8-bed psychiatric residential treatment facility for adolescents. There are 95 crisis stabilization beds across all 8 regions, and there are 100 adult residential substance use disorder beds and associated services. There are also 8 regional social centers with independent self-governance and 35 contracted entities providing statewide medication delivery and other case aid services. In addition, we also have 3 safety net contracts with private psychiatric facilities. Beginning 3 years ago, we identified a set of necessary goals to redesign our system to achieve the best results for individuals that are the most functionally impacted by mental illness and substance use disorders. We serve to improve or sustain independent function to support our clients to be independent in their home communities. To achieve our redesign, we recognized that we first needed to get the needed services to people at the right time. The development of the behavioral health walk-in provides immediate assessment and treatment for those with the most emergent needs, and treatment within 1 to 2 days for all other priority clients. Walk-in eliminated the 30 to 60-day wait time just to assess a person for the needed services, and it also eliminated the 30-plus day wait time to get into that service, which essentially resulted in about a 90-day wait just to see if you could get service. And often what would happen is either people would not return and get the needed services, or things would worsen over time because they didn't get the services they needed at the right time. This next year's goal, through the help of improved telehealth technology and the use of a statewide virtual waiting room, we plan to provide assessment and service on the same day requested, regardless of need. Our adult services that are designed to decrease symptoms of illness and increase skills for successful community living include the following: addiction counseling, psychotherapies, both group and individual, medications and medication delivery, case management, social skills training, pre-employment training, hygiene and daily living skills training, in-home support services, residential substance use disorders treatment and transitional living homes, and state hospital services for psychiatric acute, rehabilitation, and residential needs. Our youth services are also designed to decrease symptoms and improve function of youth and families. These services include addiction counseling, trauma-focused psychotherapy, intensive family therapy, medication, case management, parent aid services, parent respite, psychiatric residential treatment for a small subset of youth with reserved beds also for residential substance use services. We are also transforming our crisis services with clear understanding we have only about a quarter of the services needed to make sure that everybody in crisis in North Dakota gets the services needed. Our current crisis services include 8 regional 24-hour crisis lines, emergency assessment and screening for state hospital admissions, and crisis psychotherapy. By next year, we will have added 1 statewide call center with a universal crisis number, 24/7 mobile crisis response statewide with trained crisis workers to respond and resolve behavioral health crises at schools, jails, homes. We will have also restructured our crisis stabilization units to accommodate a variety of clients in need, with recognition that crises resolve at in different patterns, in different ways, over a different time. And the idea of what we call stand, sit, lay, which is essentially recognizing that somebody might not have crisis resolved within their home or other community setting, but may need a period of observation that may last a series of hours or days. And in addition, we are expanding our telehealth services to provide specialist consultation to our first responders. So those crisis staff that are out in the field may, on occasion, need some expert advice, expertise, and we're going to access that by way of telehealth so we can use all of the resources we have statewide. Those specialist consultants will include a child psychiatrist, behaviorists, psychologists, crisis psychotherapists, and chaplains, recognizing again that our first responders need that help, and with our intent of resolving crises at the lowest possible level at intervention. This concludes my very brief summary of the public behavioral health system. We are honored to serve as safety net for the citizens of North Dakota. Thank you.